a little while, but I got like a lot of the general stuff now. But I'm excited to revisit the topic, is what I'm trying to say.
Which topic?
So a lot of stuff that I was doing as a medical assistant at the pulmonary clinic is that I was doing a lot of, I was helping out everywhere. Like there's a lot of cystic fibrosis adult patients, lung transplant patients. I wasn't like a coordinator with the lung transplant team, but I would like help them do like the basic stuff and like see the same patients week after week. And also, but like for the general pulmonary patients, there was a lot of fellows there, so a lot of doctors in training. So what I would do is that I was sort of like their main person there, and I would field calls, take messages, talk to them over the phone, because oftentimes you tell the patient that, hey, if something's going wrong, you can see this or that, and again, I forget like the specifics, but I would like take the call, I would like ask them some medical questions. Not like I wouldn't like interpret the medical questions, but it's just like a lot of rubric stuff. So like, are you coughing up blood? Like yes or no? Like pretty simple stuff. And then I would kick it over to a nurse, a registered nurse or someone, and then they would talk to the patient more, page to doctor or the fellow that was on call at the time. So and it was also so most of the time it was just sort of like general updates on symptoms or general worsening symptoms, and you just set up like some steroids, prednisone or something. But sometimes it was like kind of scary because they were having those like big red flag symptoms, and you could hear that really crackling, shallow breathing over the phone. It was just that was sort of really tough to deal with, because when we were in the clinic was in a hospital, so if someone showed up like that, you just send them to the emergency room or do like an inpatient admit from University Hospital. So. And then you asked if I did my training at the University of Utah. I didn't do my training there. I did my training at there's a high school technical institute that I got my medical assistant training at. And then I started working there when I was 17 and then left to focus on my undergraduate degree at the U.
Well, as long as you picked up a little bit of education when you were at the U, you can't be half bad.
Yeah.
I spent 9 months down there. My wife was in the U. And so we dealt with a lot of orthopedic trauma.
Oh, okay.
Yeah, I got to know the trauma people and the orthopedic unit pretty good. ID.
Yeah. How long ago was that?
2019.
So before I went to Denver.
Yeah, most of those guys are still there, so.
Yeah, the way it is now at the University of Utah is that the ID clinic, the pulmonary clinic, and the gastroenterology clinic are all in the same space. So I never worked with infectious diseases or gastroenterology, like because I was employed by the pulmonary clinic. So, but it's all the same space.
Yeah, my experience down there was it blew me away at the doctors. Whether they were students, because we had a few student doctors versus the regular doctors.
The communication was
The communication was phenomenal. They listened to you. If they didn't know, they didn't cut the God
It wasn't
complex.
until my mom was like, brother,
Well, I'll find out, let you know. And then they would actually follow up and help you.
What do you mean?
What's around here, pretty income.
Yeah, no, I observed that about a lot of our doctors that sometimes they were like really stressed, so you never got to see like true parts of their personality. But I think a lot of times it's interesting to see that because my interactions with those doctors were pretty pleasant, and I would shadow some of the times, but yeah, a lot of the older doctors there too were really good about it.
We have some,
Right.
and they had to just got out of med school. And they were like fellowship kind of thing. Because we
So did you get your application in?
doctors that oversaw the surgeries. But she underwent
Are we going to be a threesome or a twosome?
surgery.
She was 20.
Cool.
And partway through the surgery, they'd call us, tell us how things were going.
Get the time off.
Never heard such a thing.
Well, she's in grad school.
The communication there was like far superior compared to here. I'll say that.
Yeah,
Is that your
so,
lunch?
what?
Is that your lunch?
I also had a cup of noodles. You know, I talk to people about healthy diet and we're all human.
So you were talking and I'm walking.
Yeah.
What were you gonna say?
Oh, so just because we're recording now, I wanted to say we're here to talk about effective communication between provider and patients. And these two young guys are future doctors, your second year medical students, right?
You second year.
Okay, so first and second year medical students, very cool. And in the pulmonary interest group, so future pulmonologists, we hope. It's great.
Pretty please.
Yeah.
We need them.
Yes, we definitely need more. And I know SPLPA needs more doctors, and so.
Take after doctors, that's how just he's by far the best.
Sasso, what's the first name?
David Sasso.
He's one of the pulmonologists in the St. Luke's clinic.
Okay.
Mhm. Yeah, so, and then we've got some patients here on the other side of the camera that are gonna talk about their experience with good and bad with talking to providers. And so you can learn from the good and from the bad and see, you know, what comes out of it, but hopefully better communication all around. Yeah.
Absolutely.
So I know, Doug, you said a little bit of your story from your experience. Kathleen, do you want to say what your story?
He was talking about his experience down in Utah.
Yeah.
Go ahead, talk about your experience.
Oh, it was phenomenal. In comparison.
Here, Dad.
Oh, yeah.
About having COPD and talking with doctors.
So
Yeah.
your experience in Utah was great, and you've had some experiences here not so great.
Prior to the Utah experience, it was not so good. Since
Okay.
we came back, have I just been lucky and got really good doctors on my team?
Mm-hmm.
I would say, yeah, I got lucky.
Mm-hmm. And what
My
makes a good
wife,
doctor?
not so much. What's that?
What makes a good doctor? In your opinion, what makes a good doctor?
One that'll communicate,
Mm-hmm.
listen to you. If they don't know, don't cop the God complex.
I think
Tell me, I don't know, but I'll find out.
Yeah.
Or at least try to find out.
listening to you and the family, I think that is one of the big things I will say, because just sometimes with patients, you want to say that they completely understand, but not in all cases do they fully understand.
Well, and my wife was horrible for not telling the doctor the whole story, so he can't properly diagnose it. And it took me a lot of years to figure this out, and I had an old note from the doctor. I questioned for the longest time, why are you looking at me and not her? And he says, because when I ask her a question, I can tell by the expression on your face whether she's telling me the whole story or not. And it's like, well, duh, that makes sense.
Yeah.
It really does.
And you're thinking maybe he's being misogynistic or, thank you for pulling back.
And it's not that
not
she
listening.
would lie, because it wasn't like that at all. It's just
Her
that
perception.
yeah, like she just didn't explain, or she didn't quite understand, because she had super complex medical issues.
Yeah.
And so she just didn't, like, unless it was in that moment
If
and
she
she was
did.
experiencing it in that moment,
She
she
didn't
doesn't
realize
remember to say that.
this was affecting this, was affecting this.
Well, if she didn't feel good, I don't feel good. Well, what doesn't feel good? I don't know. I just don't feel good.
Yeah. It's hard to diagnose.
Diagnose that one, would you?
Yeah.
How do you diagnose that?
So listening to the patient and also double checking with the family. And what I'm hearing you say is that it's okay to say, you feel like your breathing is good most of the time. Do you ever see him short of breath?
All the time. In fact, I actually brought that up to his provider this morning.
There you go.
He was outside. He doesn't notice anything, but his face turned completely gray. My neighbor, who was an anesthesiologist for St. Luke's,
Yeah.
So even he notices, like,
Yeah. But you're gonna push yourself farther than she would let you
I
push
pushed
yourself.
myself to the point where, no, I'm done, and I've got to sit down, and I got to sit down now. And I do that,
So a little
because
bit.
otherwise I'm gonna fall. Quite frankly, I don't need the wound care.
Yeah, yeah.
So what makes your pulmonologist now a good pulmonologist, the one you would
He
recommend?
listens to me, listens to my concerns, he explains it thoroughly, and
He doesn't
has
sugarcoat it.
never copped the God complex of it, ever.
He doesn't sugarcoat.
No, and he doesn't sugarcoat.
Yeah.
He tells me straight up, you know, like it or not, but this is where you're at. This is what you're gonna deal with, and that's all there is to it. I don't like being sugarcoated. I want to know straight up. May not want to hear what you say, but
But you need the information.
I mean, just, I don't know if that just comes from my farming background. I don't know what it is. That's just the way I've always been. Just give it to me straight up. May not like what you have to say, but
That's kind of an interesting point too, because you like it straight up. You want to hear it plain as day, but there's probably a lot of people who want a little sugar on top, right?
yeah, I'm sure there is.
And how do you differentiate?
And I'll give you an example, because that one provider in ICU with my mom,
Dr. Hill,
and I wasn't listening,
you know what I'm talking
Yeah.
about.
was I just wanted to punch him in the face.
Yeah, because why?
The way he communicated was terrible. Like, he wouldn't listen. He knew what she needed, but they traumatized her in the process of doing that instead of just listening to me to begin with. Like, I know when her breathing tube could come out. Like, I get that they're a pulmonologist, and I get that their medical degree is clearly better than mine. However, I am the one that takes care of her 24/7.
Right.
I know where she was at. And if they would have just explained things more thoroughly.
Yeah. Then you'd feel like you're heard and you're not just being pushed off because you don't have a medical degree.
Right. Well, and the fact is they traumatized her in the process of doing it, because they pulled her tube. And then
Prematurely,
Um,
and then had to put it back in a couple hours later.
Yeah.
instead of knowing, like, I could have explained to them, like, well, she had all the esophageal, you know, like, she doesn't swallow super well to begin with, you know, and explaining some of that. And so there was just a lot of that. Like, if they would have just communicated, I get that maybe some people don't need that, but other people that maybe are a little more familiar with their loved ones, or care for their loved ones consistently.
Yeah.
I think sometimes maybe those people might want more communication than
Well, there's
people
a
that
difference between a
don't.
patient whose smile is that thick versus hers that's like this.
Sure.
There's no way. It would take them a month of reading to read all of hers.
Sure.
If you just listen to the family, they can fill you in on a lot of it just
Yeah.
quickly.
I think like reading the room too, right? Like, I mean, I know you well, so I know that you like a lot of communication. You want to talk things through, and you want to have a joint understanding and a joint decision. Like, this isn't, and I think most people are like that, but some people do get overwhelmed. And if you're explaining things to people and they start to kind of glaze over and they just look like this is too much, then like I can never imagine you having that look. Like, you're like, give me the more information. But some people do. They're like, whoa, this is, and maybe just asking.
Because, like, when I called you, or when I called Tara when he was in the hospital last time, because I was getting
You weren't getting listened to.
flustered
Yeah.
and on the verge of not very
Of getting kicked out of the hospital.
Yes.
Wasn't flustered. Another term for it.
That I just felt like, had they have just listened, that we could have skipped a big majority of that. And his hospital stay wouldn't have been as long.
Yeah.
Which is always a good thing. Right. For all concerned.
For all, yeah. So the hospital wants to reduce your length of stay because we always have people boarding in the ER waiting for that bed. So we don't want you in the hospitals. We have plenty of patients. We don't need to keep you. We want to get you in as quickly as possible.
Then why don't the doctors listen to the patient? Follow the patient directions?
You know, because when they were learning, they didn't know me and they didn't come to this group to meet you guys. I don't know. Hint, hint.
I know me better than they know me,
Yeah.
so maybe they should listen to me a little bit.
Yeah.
And that would help reduce my stay.
Oh, yeah.
Yeah, that's one thing, is that's what a medical degree gives you. It gives you the breadth of knowledge of the human body. But the thing is that it's only for like general statistics. It's about like the norm, what like, this is the book, textbook cases,
About
right?
70% of most people.
Yeah.
You have that 15 and 15 that's plumb off the chart, or it isn't even on the chart, that you got to read that too.
And you have to trust the expert on those 15% populations, and the expert on that is whoever, either caretakers or patients themselves. I've seen it a lot where it's like you have to rely on that person who's driving them to the hospital, or like just sort of working with them and being like, yeah, the traffic here at the University Hospital is horrible. What can we do? And tell them that, just constantly trying to make it easier on them too, because there's a lot of stress that I see, that I saw, having to work with the caregivers, having to make sure everything's coordinated, especially like older patients is sort of like the appropriate term, but like really approaching like elderly age.
Mm-hmm. Because if you put
We know nothing about the elderly.
No.
If we put barriers in for like the traffic is really bad, the parking is really bad. You put these barriers in, then they're not even going to come and see you to talk to you. They're going to cancel their appointment. They're not even going to come see you and talk to you in the first place.
And some of these patients are like 18, 19-year-olds with quadriplegia. They can't move any of their limbs, and they have like a permanent tracheotomy. They can't even hardly speak too. It's just like this. How do you get that person from 3 hours away in Utah to Salt Lake City, back and forth? Like, it's just way too complex. The problem is that those patients have to be seen in person too. There's not like they have to clean your trach, they have to check, they have to, if there's an issue, they have to get the bacteria. So it's just too much problems.
Yeah, it can be really complicated. So talked about the bad, and now maybe the good. Like, you love Dr. Sasso because he gives it to you straight, doesn't sugarcoat it. Is there anything else that kind of stands out with why? Yeah, that's a good
With
point.
you guys, because honestly, both of you were the saving grace for me when he was in there this last time when I wasn't getting anywhere.
Yeah. It's like a little backstory, not too much, is one of the issues last time you were in the hospital was you take your breathing treatments like every 4 hours, and they switch you off of your home regimen because that's not what it said in the chart, because it was listed as PRN, but he does do it every 4 hours.
Well, and it was different because it's
Duonev versus, yeah.
So that was a DME.
and he does actually both. So it's not just one or the
I do
other. It's
albuterol in the
both.
morning, then Duonev at noon, Duonev again at 4, then albuterol at night when I take the
Breast treatment.
breast.
Okay.
Yes.
So the DME just got some incorrect order.
No, it was in the hospital. So he was in the hospital and they just ordered like generic whatever for your breathing treatments. And then you didn't get them on the schedule that you're used to, and you're there with breathing problems, and we should be escalating, not de-escalating. Right?
Well, I wasn't there for the breathing problem. I was there because of
Combo. You were
cellulitis.
He got switched to my hospital, he got switched to what he was supposed to be on, and then they switched him back because they just felt like it wasn't right.
Yeah.
You know, he was saying, this is what I do, this is what I do, they just automatically switched him back to what he was. Even though I had already switched him to do that, the albuterol, so when I came back, I had switched him back.
Because,
Automatically switch.
yeah, so the doctor,
The hospitalist didn't understand
she thought it was
that you don't take breastfeed with dual med. It doesn't do any good because that blocks the channels for the breastfeed.
Yeah.
If you do the
She
dual
was
med.
too stupid to understand that.
Okay, so technically, if you're going by the book, you shouldn't be doing Duoneb and Breztri because they both have an anticholinergic, and so you're not going to see much benefit because you're already saturated with the anticholinergic. But whatever, that's what you do at home and it works for you. So
I tried the albuterol at noon and 4. It
Wasn't
like
enough.
shit.
yeah,
And I had some dual neb. I tried that. It worked.
yeah,
Dr. Sasso said, well, hell, if that's what works for you, then
Exactly.
by all means, that's what you need to do.
if it's working for you and it's not causing harm,
Yeah. Just don't do the dual
Yes.
neb and then try to use the breastfeed because it's not going to work.
yeah, you want to space
His
it.
term to you was, he's just more difficult. That's the nice way of saying it.
Mhm.
So, to do what works. That's what he said.
Yeah, so and then it causes you guys undue stress, and then you're calling me at like first thing in the morning and saying, what the heck is going on? And which, like, rightfully so, please feel free. But yeah, it's a mess, and it's not, that wasn't the doctor that, I mean, they were involved, but it was the respiratory therapist who changed it back. So it's,
Yay for respiratory therapists.
no, who changed him, she fixed it, and then another respiratory therapist came and unfixed it.
Was the respiratory therapist that unfixed it, or was it the doctor that unfixed it?
The doctor did, and the respiratory therapist, I think, left a message for you. Is that correct, Tara?
I don't remember anymore. I think the doctor's the one that changed.
That's
Yeah.
what
I
I
think they
thought.
just automatically thought it was wrong.
Oh.
They just changed it.
Communication, weird.
Yeah. But yeah, respiratory therapy. Because again, I was mostly outpatient, so in our clinic we would always have like one gas respiratory therapist, and they were great. Because man, every time I had to do a walk test by myself, it was so difficult. Because like I don't know, or I had to send out DME orders. It's like there was like 6 different ones I had to keep juggling to send the Medicare forms and whatever. So it was just so nice to have an outpatient respiratory therapist in those settings because they were. Like again, like they had to figure it out from scratch too. It was just a lot nicer to just rely on them to be there. And when they weren't there, I felt it.
Yeah, team approach is great.
Yeah. But I think that's right. So I think it's beneficial for you guys, obviously. 'Cause
Yeah.
For me, it was the only thing that seemed to work.
Sometimes it's hard too because I feel like the providers don't communicate their plan so well with us also.
Well, they sure as hell don't disclose it to the patient.
Yeah, I mean, you guys get even worse because we can read the notes and we get like kind of an idea, but sometimes, and it's a balancing act, right? Like how much time can you spend talking to every single person on the care team when like you're also supposed to be reading charts and actually seeing patients and assessing them and responding to emergencies. Like it's a balance, but
And I noticed, I don't remember which time it was, but they discussed the care with me.
mhm.
Walked out of the room and wrote something else in the chart. And,
Oh.
and
I
it's
changed
like,
it
seriously?
last time, and that's when he like,
Yeah.
and that's when I called Tara.
Oh, no. Yeah. Sometimes we forget that the person in the room 18 is a living, breathing person with a name and a family and a history, not just room 18. So that's,
Well, that guy down at 405.
yeah, the curmudgeon. Yeah. All right. Well, how about you, Kathleen? Do you want to say your story?
Sure. I'm going to tell you good and bad stuff.
Okay.
I'm going to leave the names of the bad stuff out.
To protect the kids.
But I've had some good stuff too. I was diagnosed with COPD in 2019, and I was diagnosed because my PCP thought I had asthma. I had an attack in the middle of the night where I literally was going, "Ah!" And that was all I had. So I went to my doctor and they said, oh, let's get you tested for asthma. And so I went to St. Luke's downtown Boise and did the PFT, the full, actually what they set me up for was a metachlorine challenge for the asthma. And they couldn't give it to me because they did the PFT first and I was too low. So they said, we can't give you that because that's very dangerous. And
It's got to send you to the ER.
yeah. And, but I didn't understand any of it at that time, you know? So I'm like, okay. So they did the test and she said, you know, results be back to your pulmonologist, because my PCP had sent me to a pulmonologist and they said, do this. And so I waited a week and a half, close to 2 weeks. And I called the pulmonologist's office and I said, I had a test and I was supposed to have had the results already. And she said, well, let me look you up. Like that. And she said, well, I have the results here. And I said, well, can you tell me what they're? She goes, yeah, you've got COPD and asthma. And I'm like, that's how I found out. This was the office girl. So that's how I found out. I was pissed off about that.
Yeah.
And alarmed and pretty upset because I figured they should have done their duty. And I should have been talking with the pulmonologist when I found out I have COPD. So then, of course, had the appointment to go in and talk with the pulmonologist. And they gave me a treatment, which is a perfectly legitimate treatment. It was Trelegy. And the problem is they didn't explain it very well. And I'm one of these people that believes in the proof is in the pudding. So after a month of it not feeling any better, I said, well, this is shit. And I didn't keep getting it because it was expensive as hell. I'm like, there's nothing going on here. I still feel like crap, God damn it. Sorry. And so I didn't use it, you know, and I was supposed to go back in 6 months and I did. And I said, well, that didn't work. And he goes, well, what do you mean it didn't work? And I said, well, I didn't feel, you know, it's not making me cough less or any of those things. And he goes, how long did you use it? And I said, a month. And he goes, you know, I'm like, well, you should tell me these things. What's the expectation? What does this do? So that's one of the things I always try to mention is if you're giving somebody something like that, I mean, COPD, it's not going to cure it, number one, right? But what will it do and what won't it do? And how long should I wait? And what am I looking at? Those are things that I need. And I didn't know I needed that until all this started happening. Now I look up everything, but at the first I didn't. I was relying on them to tell me. So is that on me? Yeah, a little bit. Is that on him? Yeah, a little bit.
Something interesting about that, because obviously the onus is on the physician. It's him or her that's right. Like the label, their name is on that label for that drug, so it's on. The onus is on them. But one thing that was great about where I was working is that some of the doctors with really complex patients, like even really complex COPD or asthma patients, like they would have a clinical pharmacist with them. And they would come in and they would do the education.
Do the whole thing.
And they would learn about thrush and all that stuff. Like, and then there were nurses there who could also sort of like give the inhaler, like how to use a spacer and all that stuff.
Yeah.
But it was so great to have a pharmacist there. And the pharmacist would do a lot of like interfacing with the wide constellation of current drugs, biologics, all that sorts of stuff.
Their pharmacists are wonderful. Given any opportunity, they're fantastic. Absolutely.
Yeah.
So that was my first no. That was my first down. And then after that, I never saw the pulmonologist again. I saw what's wrong.
Yeah. He's a nurse practitioner.
Nurse practitioner. So I saw a PAC. Is that the right? and then, and our PA and nurse practitioners after that. And I'm not saying anything bad about any of them. They were all very decent, nice human beings who did what they were supposed to do. But I was a little upset that I never saw the pulmonologist again, because basically what the pulmonologist said was, you have COPD and you have asthma, and this is what we're going to give you. That's all. And being who I am, I said, okay, well, I need to find out some stuff because I don't know anything about this. And so I did. I found out a lot of stuff, and that was great. But I really resented the fact that I never saw the pulmonologist again. To this day, I've never seen the pulmonologist again. And I did not have another PFT for 3 years. And it wasn't the pulmonology office that gave it to me, it was an allergist. And that's when I found out that, you know, it was not doing so good. And so I got some albuterol.
Because they only gave you Trelegy.
Trelegy, that was it.
They didn't give you an albuterol then either.
No, no. And so I got the albuterol. And it was amazing. I started feeling better.
Yeah.
Because the Trelegy was fine. And I am still on Trelegy. And I'm very happy I'm on Trelegy. But when it's really kicking me, the albuterol is the difference that makes the difference. And I don't even get the shakes anymore.
But they told you you had asthma and COPD.
Yes. And Trelegy is supposed to treat both.
Yeah, but
I know, trust me, I know.
Did you hear that from a doctor or from a pharmacist?
you heard it from the front desk person.
Well, first of all, back to the old doctor on me. First thing he told me is we only spend about 8 hours education on medication. You want to know something about drugs? Talk to your pharmacist.
Yeah.
It's true.
And I have lived by that, and I've had some really good pharmacists.
Yeah.
And I can call them anytime.
Yep.
Whether it's for a prescription or
Yeah.
I want to know the contradiction to this, and they'll spend 15, 20 minutes on the phone with me.
But I guess that's like an excellent takeaway, right? Like the doctor, I don't know a whole lot about your meds. Like I know this is what you need, and beyond that, you know, these are the basics, but I'm going to defer to the subject matter expert, which is a pharmacist, to tell you the in-depth stuff you need to know. Like if they had done that for you and said, I'm going to put you on Trelegy, when you get to when you pick it up at the pharmacy, tell them you don't know anything about it, ask questions. That would have been way more sufficient.
I think, yeah.
For me, I was on Symbicort.
Mhm.
And talking to the pharmacist, said, well, Resveratrol worked way better than Symbicort. So when I was in the hospital and I'm at Sasso, hey, what about Resveratrol?
Yeah.
I understand that's better than the Symbicort. And that's when they changed to the Resveratrol over the Symbicort.
And that's when you started seeing Sasso. That's from that.
I got out of the hospital that first time and I saw a PA over in Nashville. And from that point on, I've never seen a PA. I've seen the actual pulmonologist.
Because you asked to.
Because I'm a pain in the ass.
Yeah.
If I'm paying, I want to see the doctor, not a PA, not a nurse practitioner, the doctor.
Yeah, that's valid.
Well, but you do, and let me rephrase this too. He does see nurse practitioners, like his primary is a nurse practitioner that comes into our own. And he likes them a lot.
Yeah.
He's fantastic. The reason he liked Dr. Sasso and wanted to continue seeing him is because of the way Sasso communicated
Yeah.
with information and listened when he was in the hospital.
Yeah.
So the most important thing to me when it comes to my pulmonologist is the fact that they don't test for alpha-1 antitrypsin. That is the most important. And the reason it's the most important thing for me is because I found out through my research at COPD Foundation, there was such a thing called that. There was a genetic factor that could, even if you don't smoke, I smoked, but even if you don't smoke, that you could get COPD. And so I went to the Alpha One Foundation and tested and found out that I have it. And the reason it's the number one factor is because if you don't test the patient, they can't tell their family, and they can't do anything about that family's lifestyle going down the next generation. My dad died at 53 from COPD and liver damage.
Ding, ding, ding.
They weren't testing for it then, you know, it didn't happen. This was a while ago, obviously. But, you know, I have kids and now I have grandkids. And because I did that effort and I took that, they now know that that's what runs in our family and can act accordingly. That doesn't mean all of them do, but they have the opportunity and the knowledge.
I worked with Dr. Carol Perosi at the University of Utah. She was,
Yep.
that was her bread and butter, was operating trips and clinical trials and that.
Yep.
That was great working with her and seeing a lot more of that. Because with alpha 1 antitrypsin, or at least what she was working on was like, it's like you're saying, it's so new and it's so, we know maybe a little bit more now, but again, like.
A lot more.
It's
been 30 years since they've been doing it now, and it's phenomenal, the changes that have been made. I go to all of their educational, they have educational days, usually about 6 of them a year.
Okay.
And I either go to virtually or actually in person, and
There's going to be one here in Boise in September.
Oh, interesting.
Yeah. So stay tuned.
Put it on your list, trust me.
Why doesn't the pulmonologist, did you ever get an answer like why they don't?
Because
actually test for it?
right now, nationwide in the United States, 1 out of every 6 people that have COPD get tested. And the ones that get tested are the ones that didn't smoke. If you smoked, you don't get tested. And
that's why.
my answer to that is,
So you just lie and say you didn't smoke?
well, no, but who knows that when they walk in? You don't walk in saying, I don't
That you should
smoke.
lie to your doctor. Like, you don't. I mean, maybe you do.
Like, what? Do you honestly think if I knew that I'd be like, yeah, no, I didn't smoke? I'd say that in a heartbeat.
And, well, and the other, I'm going to reference that really quick, because the other thing that I know for a fact is that there are a lot of patients who did smoke that have COPD, and they've got a lot of shame associated with that because they were stupid and smoked, you know, and they did it to themselves. And as a result, there's a lot of them that don't do a lot for themselves that should. They don't go to pulmonary, you know, rehab. They don't, you know, they don't get up and walk at least once a day. They don't do those things that are going to help them with their quality of life now because they're ashamed, and they just sit in their home and they go like that. And I know that for a fact. And one of the issues that happens, and I'm not saying everybody does this, because it wouldn't be true, but there are people in the medical profession that, well, you smoked, what did you expect? And that attitude, shut it down. If you ever hear it, shut it down. Nobody needs that at that point, you know? It's like saying to a diabetic, well, you had sugar, for God's sakes. What did you expect?
You go ahead.
I had asthma before I ever started smoking. And after I started smoking, I went for 45 years with no asthma attack whatsoever. And I was every 3 months in the hospital because I couldn't breathe from asthma. From the time I was an infant till I was 13 or 14. And then I started smoking, and I never had an asthma attack again.
And I will say the same thing. I was hospitalized a lot as a kid.
With asthma.
With asthma.
I was hospitalized with pneumonia.
With
4 times.
Severe.
Kid?
Yeah.
And same with me.
Yeah.
And you know what? When I started smoking young at 16, I did not have near the asthma attacks.
Well, I never had asthma until onset. I have what's called eosinophilic adult onset asthma. And so I've got atopic dermatitis, I've got the
Got
eosinophilic.
inflammation.
Yes, I got inflam.
Yeah.
One thing about smoking, real quick, it's the 50 attorney generals of all the United States don't come together and take hundreds of billions of dollars from the tobacco industry and bar them from advertising on anything ever again for no reason, right? Like, shame to me as far as smoking, especially in those generations where they had Marlboro on this Formula One cars, Ferrari, those. It's just like you
Don't
can't.
get those candy
When you
cigarettes.
go into the doctor's office and there's his ashtray and his cigarette.
Yeah,
Seriously, because it was that way.
yeah. It's just like they got hundreds of billions of dollars in that lawsuit, and they said you can never advertise again. Like, what do you think had to have happened? What do you think they were doing in that time frame? You can't really just like say, "Oh, you smoked, you're the problem. Goodbye. Like, here's the medicine. Goodbye."
The culture,
Like,
yeah.
What?
It's the culture.
Yeah, it's
You couldn't go in any office, any place. You couldn't go in any restaurant, office, bar, in your home because my parents both smoked. Everybody smoked, literally.
And I remember growing up, Salt Lake City International Airport, like every 5 gates, there'd be a glass room. They don't do that anymore. They don't build those anymore. They say if you want to smoke, leave the airport. And it's just like,
I
Yeah,
always thought it was the coolest thing because when we were at the airport and I saw that in Salt Lake, and because his family is LDS, and so like I just always thought it was the craziest thing being in Salt
In
Lake.
Salt Lake, yeah.
And we're in Idaho, and they don't even have Salt Lake.
well, that's because in Idaho, you just smoked all the way through the whole thing.
That's wild.
Interesting. Smoking. When you hear that, well, I don't need to test for alcohol in this patient. And I think speaking like from our sort of experience so far, I'm obviously for a lot of kids, but when they teach us of diseases, different diseases, right, they teach us like to look out for risk factors, smoking, alcohol, stuff like that. And even when we do like standardized patient encounters, we have people coming from the community like act as like patients with real illness, right? It tells them, pay attention to what they're saying, pay attention to like, ask about history, like hear what they're saying about like, alcohol use and drug use, stuff like that. And it's sort of like I know like it's scary, but now it feels more like just a data gathering, right? And
Yep.
so like we kind of take that in and we're just like, okay, we assess for any risk factors like that, but we don't like, I guess, we like fully think about like the background behind that.
Yeah.
Just hear someone say, "Oh, I smoked a pack of cigarettes for 30 years," like right, that's 30 factors. But we don't really try to follow up behind like, is there a reason why you decided to smoke that much? And then you decide to like, sometimes we need to jump to conclusions like, oh, this person smoked a lot, so that's how like you need like a respiratory illness. Like I don't need to still do a genetic testing for any gene mutation.
Yeah, I obviously feel very passionately about it because it makes a difference in my family, and I was really upset.
You asked to be tested.
Yes,
She asked a pulmonologist to be tested, and he said, you don't have that.
you're a smoker. That's, and then the evidence now shows that even if you're a carrier, an alpha-1 carrier, quote unquote, that's what they used to call it, is you're still more susceptible, both in liver and in lungs, even though you're just a quote unquote carrier. You're not supposed to use that term anymore, but everybody does still use it.
yeah.
And it's like,
Mutation.
yeah,
Because that's a,
Didn't you ask Dr. Cecily about that as well? And he gave you some explanation about it.
Yeah, I don't remember what it was, but it was basically, well, because you're a smoker, it doesn't matter.
yeah,
He said
because
the treatment would be the same regardless, is what Sasso was saying.
Okay, and there's some validity to that. There's a lot of
it's
providers
absolutely true.
who don't believe in augmentation therapy. It's expensive. They say it doesn't improve your mortality, but it will improve your quality of life.
Absolutely.
And if you don't need treatment, okay, fine. But like the trickle down effect of your,
What about the rest of your family?
Yeah.
If they know that, there's an opportunity for them, that I did not have.
So is that something that I can say, well, I want him tested regardless?
Yep,
yeah,
absolutely. He can go to Alpha One Foundation online on the web, and there's a little thing that shows you, here's the testing, and you can do it.
They send it to your
And it
house.
comes directly to you.
You don't
They'll send you the thing to test with, fold it up, and you send it back to them, and then they'll send you the response, the letter saying exactly yes, no, and to what degree.
Is it a blood draw or?
Yeah, it's like 3 drops of blood.
Like probably a prick, like a diabetic thing.
Yeah.
Yeah.
How much does it cost you?
It's absolutely free. When you go through
Get the
Alpha One
information from
Foundation.
her.
So you're gonna do it regardless.
There's a professor at our university who's really into that. And the thing is that a lot of people,
Yeah, and it's
his
just
lectures are quite hard, because people probably. Yeah, so, but the thing is that the reason why he's so hard on that and knowing that sort of stuff is because he wants the students that he teaches to be aware of these long-lasting genetic consequences. He really does care about those sorts of, the genetic spread of these things, because, even though in your own life, through your own choices, of course you were predisposed to risk factors, and of course, it wasn't really, it wasn't by your choice that you had that mutation, or your choice that that happened to you, but you can still do something about it to your children, to
Absolutely.
further on, because
Yeah.
they wouldn't know. They'd be like, oh yeah, I look in old photos and I see my grandmother smoking, or something like that. It's like, yeah, this was all, or
Yeah, that's it.
like you just have to like know that you were dealt a bad hand of cards, but how do you play it? How do you go through life with this, knowing that what you have in your.
Yeah, and the difference for somebody with Alpha One is, I was never much of a drinker because I'm such a lightweight, and so I just didn't. My father was a drinker, and when drinking and Alpha One, and he was a ZZ, his genotype was ZZ, and we're assuming because he had both so young. His liver was just gone. His liver was just gone because he drank. If you're not much of a drinker, you aren't putting that added burden on it, but I've never been much of a drinker, so my liver is not showing any issues.
Yay.
One thing's good.
Yeah, yay. So that worked great, but both my kids partied quite a bit.
Well, I partied pretty hard for about 20 years, but
Yeah,
my liver is
good to go.
good to go. So
One thing we got, go livers.
lungs, on the other hand,
Not
they're
so
on the
much.
way out.
Not so much. What kind of questions do you guys have?
I've been asking them that too. There is one thing that I had when we were talking about NPs and PAs. In Utah, it was recently changed that NPs and PAs had a lot more jurisdiction, like they could practice without physician oversight. So like in the clinic where I was working, like there were PAs that worked with doctors, but oftentimes like they were seeing their own set of patients. They weren't like constantly consulting. Like they would, like if something was like really confusing to them, they would ask the pulmonologist with way more years of experience and also medical degree, board certification, what have you. But in Idaho, I know it's like slightly different with PAs and NPs, like they need physicians.
The nurse practitioners can practice independently.
They can practice independently.
Yeah.
Okay.
But I think the issue here is that in the clinic, the pulmonary clinic here, you'll see the pulmonologist, and if you're deemed kind of standard, like not very complicated, kind of whatever, then you get passed to a mid-level provider,
Yeah.
unless there's something that comes up that makes you more complicated, and then you meet with the pulmonologist again.
And the other thing is nobody ever explained what an exacerbation was.
Yeah.
I always thought it meant I had to go to the hospital emergency room. So when everybody said, da, 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 have you had any exacerbations? I was exasperated, but not exacerbated. I would say no. I haven't had to go to the hospital. And I think it was you that I finally got that information from one time, because I said something like, well, I haven't ever been to the hospital. But yeah, that's a bad time. And I did not know that.
Yeah.
So I'm like, I filled out all the paperwork wrong. No, I haven't had any exacerbations. And this is to the PAs, and they're like, well, we're just moving right along then.
Keep going the same.
Yep.
Yeah, and maybe just explaining that, hey, you seem like you're well controlled, and so you're going to see the mid-level provider, unless something else comes up. Then you would say you wouldn't feel like you just got passed off.
Right.
You would say, hey, this is how we do it, so that we can spread the pulmonologist,
Right.
Wider. Because that would make more sense, right? Like the pulmonologist, you can't see them every single time because there's not enough of them.
And no,
And
exactly.
that's reasonable.
That's one thing I know, just because in the university hospital clinic, like in order to change doctors, you had to go to the clinic manager. I don't know
You
why.
can't change them here.
Yeah, at all, you can't get a transfer.
No, I tried. I have tried and tried.
I did. I changed doctors.
Yours was a little different too, though, because you saw him in the hospital and then he followed you. Because you had somebody else, and then Dr. Sasso just happened to be on the week that you were there, and so.
Well, and we specifically asked him,
Can you take over?
Can I switch? I like you better than the other one.
Yeah,
And I switched. And he said, oh, yeah.
you can. They don't make it very easy,
No, they don't.
especially if. Yeah, they don't make it very easy.
Yeah, there's always some.
Because I don't go to the hospital.
Yeah.
So.
Well, I try not
Exacerbation.
to, but sometimes you just ain't got a choice.
Yeah.
Yeah, one explanation I got for why they had to go to the clinic manager is that he was sort of like an arbitrator. So like the doctors were like butt heads and like have ego conflicts. So they just like, okay, the patient wants to change, I'm changing because I'm the clinic manager. So that's the only explanation I got. Maybe there's some other, but and I thought that was pretty acceptable.
Like field complaints.
Yeah, but also as far as like the whole like pulmonologist shifting it down to mid-level providers, it's tough because there's the scheduling standpoint too. Because like we said at the very beginning, there's a dearth of pulmonologists, and
Precisely.
one of the
That's why we want you guys to be pulmonologists.
one of the doctors I was working with, I was regularly booking him at 200% over capacity. I was double booking every single slot because he was also a professor, so he'd have some conflict. But again, it was just like he was saying 200%, 250%. And none of the patients really minded because they really liked him. But obviously, it's a little bit harder to, sit there for an hour. And it's like, oh, I'm sorry, he's double booked. Like every 30-minute slot has been double booked just because people want to see him and his team. And it's even harder with those fellows too, because they only had clinic at the university hospital for 4 hours every 2 weeks. And in between that, they would have 1 hour and new patient visits, 30-minute return patient visits. So oftentimes I would just ask them, what do we do? Because you're booked out for 4 months. Because the churn they were having was so bad, and they're like, okay, we have to put him somewhere. This patient might be okay, or this patient, you know what? I'll eat lunch in the office. Put him at 12, and then when they would get done with whatever rotation they were doing in their morning, they would have to come they would come a little bit later because they travel from the VA or wherever to university hospital. But that was so difficult to see. It's just how do you just juggle this? And there's just so many. It's such a delicate balancing act. And I was the one I was a fulcrum for all that for quite a while. So I was experiencing all of that. Like, I couldn't imagine how I felt as a patient to have to go to this, be waiting a lot. And I was trying to make it easier to juice, water, whatever, but there's only so much I can do as a medical assistant. Just checking the blood pressure and scheduling appointments, right?
Mostly if you guys could just remember to please test. That's my biggest, that's my number one priority is just test.
Yeah, I think also like knowing your resources too. Like if you don't have time to spend with a patient because you're double booked or whatever, and you say, okay, I'm diagnosing you today with COPD. This is like the quick down and dirty what you need to know, but I would like for you to go on to the COPD Foundation website and look at their resources because they've got a lot of patient education.
And they do, it's phenomenal.
Yeah.
If you guys haven't ever been on there, it's the videos that they've got, the education, it's phenomenal. Really,
Alpha
really
One
good.
has great education.
Alpha One Foundation has wonderful stuff on
ALA,
there.
like Asthma and Allergy Network. I mean, there's like so many. There's the IPF.
And then if you've
Foundation.
never watched the, what are they called, the ninjas? YouTube,
Oh, Ninja?
Ninja Nerds, yes, those guys, they are the greatest ever, greatest ever.
I try, because I have a midterm tomorrow in
Uh-huh.
neurology. I tried watching some of those videos, like sometimes it was like okay, sometimes it wasn't, so.
Well, I know
I'm
the
glad it helped
pulmonology
patients.
stuff is
I'm
good.
very glad it's for patients, it's able to help them grasp it, because I didn't realize that, because whenever I saw it, it always seemed a little bit complex. I was like, okay, I can't deal with a guy walking through this, I have to learn this myself and then watch it. So, but it's good that they can just like step.
Yeah, the Ninja Nerds, as far as I'm concerned, when it comes to COPD, they took me right down there, and I'm just like, okay, I've got a foundation now. I know what the hell is going on. And that to me is really important. Just ask her.
Or just like sending people to pulmonary rehab because then they're going to get education there.
Oh.
Yes.
You know?
Huge.
And then, and the other thing I wanted to add was knowing that 9 out of 10 people in this country do not have that health literacy they need to be able to navigate the healthcare system effectively, right? So there's 1 person out of 10 who can navigate the healthcare system effectively on their own. So I mean, keeping things simple, explaining things at like a level where the person can understand. Sometimes you think that like it's a really complex issue and you want to explain it to a patient, but you need to explain it to somebody who has no background. So
Or knowing
way lower.
which person and how you're explaining it.
Yeah.
It's not necessarily what you know, but who
Yeah.
Well, I just think, like, some people may not know the resources, but clearly there's other people that do.
Yeah. Yeah.
Yeah. You mean
Yeah, true.
Like peer advocacy groups, right?
Well, yeah, or just working in that field
Yeah.
before being a stay-at-home caregiver for a parent. Like, I have those resources and I know that. I do know some things, like I'm not completely illiterate,
But you're always asking.
but when I want some information, like, yeah, I expect it to be given. You may not know.
Yeah.
But be willing to find out.
she's not gonna stop till she gets what she wants.
Yeah. That's
And I'm
good.
probably gonna push buttons along the way. Because if you put me there, I'm probably already past the point of injury.
There was one provider I was working with. He would try and explain these concepts to patients, and he would always go late. Like literally every time he had a clinic, he was running late because he spent time walking patients through it. And like obviously, like I can see it and I can appreciate it, the press Gini scores and the statistics of how like it was all 5 stars, right? People were rating 5 stars, but it's just sort of like just the time it takes and then the pressure on you from other patients. You have to have a full clinic. It's just so hard to balance everything. I don't know how to rectify that.
More doctors.
Yeah.
Well, and I think probably some people, I don't know, like if they started explaining statistics to me, I'd probably be like, I don't care.
Yeah.
I don't care about statistics. I care about the individual. You know what I mean?
I'm not a statistic. I'm a human being.
Right.
Yeah.
Yeah. It's very true. All right. I think we'll wrap it up. Okay, so key takeaways.
You guys have been right.
Yeah.
No, I wish I could.
It just.
I wish I could spend long.
Yeah, key takeaways, communicate with your patients. At a level that they can understand, answer questions, listen to family, test for alpha-1, send them to pulmonary rehab. Anything else?
And if you ever have the opportunity, take a class called motivational interviewing.
Oh, yeah, that would be
That is
really nice.
Where is that?
Just
Anywhere.
just YouTube it.
YouTube
Motivational
it.
interviewing.
There you go.
They offer lots of free ones. I used to do the training.
It's wonderful.
Yeah,
Okay.
really, it was designed for smoking cessation.
Oh,
And
But if every caregiver on earth had the opportunity to take that, it would be a really good thing.
Yeah.
A really good thing.
It was mandatory in the mental health field. You had to have so many credits every year.
makes sense.